Thank you, everyone, and it's my pleasure being here today. So I will be talking more on clinical foundation models trained on structured real-world data. So Dr. Washu already covered using clinical notes, which like text data. We will focus more on those codes that are there in the electronic health records, and you can also have access to them from claims data as well. Okay, so my agenda is briefly, I will talk about, give an introduction about what is a structured clinical data look like, just in case some of you are not aware of it. Just a brief description, what is the meaning, or when we talk about foundation model, what we mean. Talk about more on clinical foundation models, more on MedPERT, which is our original foundation models that we published in 2020, 2021. And a little bit use cases and the future work and current advancement in this domain. So this is just like an example or a summarization of how an electronic health record will look like. So as you can see, a patient can come for a number of visits. He can have this is a patient who had an accident. He stayed in the hospital for 3 days. And you can see there are a number of diagnoses, lab tests, some medications are taken at different time points during his stay. He come back after a few months, and then he had an outpatient visit. There are also some diagnoses there. The doctor prescribed some medication. We have the patient demographics already there. The age will be changing among visits. Sometimes we will have some visits that we can see it in the electronic health record data, but we don't see any information. We see an encounter, we don't see anything associated with it. This has come something with I'm always saying EHR data is very rich. We can get a lot of information out of it, but it is messy and it has a lot of quality issues. We need to consider that while we are working with. So in all my research, starting when I started joining Dr. Z Lab in 2017 and working on deep learning predictive models, at that time, I always have an analogy in my head. I always see the patient information or the electronic health record for a patient is a patient history. It is a story. It is the same as a text. So the same way we model the text data, we can model the electronic health records data for the patient, even if it is structured. But there are a number of variations there. And if I just refer to it here, you can just say the token granularity. When we are talking about large language models and talking about tokenizing, it is just how we are representing an entity. So normally in natural language, we are talking about words or even piece of work. But when we are talking about electronic health records, mostly we are referring to codes. So as I have seen in that example, you have some ICD codes, for example, to represent a disease. So instead of using the motor vehicle accident, I just refer or have one token for E819.9. Also, when we are talking about the syntactic or the hierarchical structure, so as I said, the text can be a document. Within the document, we have paragraphs. Within the paragraph, we have sentence, phrases, word. Looking at the patient, we have the whole patient history. It is a story. The patient have come to the hospital many times, different visits, and within each visit, there are different codes of different categories. So this is mainly another difference between the natural language and EHR. Another one is the sequential order. So in text, like a word after the next one, there is no time information, there is no temporal gap between these codes, but this can be the case in the electronic health records. Also, when we talk about the semantics or the meaning, so the dependency relations are very clear to the average human. When we are mainly talking about text, we can read it, we easily understand, but this dependency is somehow unclear in the electronic health records. You need to be a trained clinician to have a clear understanding of what is the meaning of these codes or what is the correlation of these codes. And sometimes also this is pretty challenging because you can have a disease and a medication. And you don't know if this disease is a side effect of this medication or this medication was prescribed because of this disease. This is somehow is not clear distinction we do have here. I mentioned before, like the time interval also, it is irregular in the EHRs, and the data completeness, mostly it is incomplete, as I have shown in the example, and the sequence length, it is pretty variable, especially when we are talking about like patient history for more than 15 years, which we have it nowadays. So when I started like this, my first paper published like in 2018, we think like pretty simple. We have the EHR data, we will have it to an embedding layer, we have the RNN model, which will be our prediction engine, and we have the clinical outcome. But when we started, we find there is a lot of challenges there, and there is a lot of things that we need to consider modeling the structured EHR data. And what I'm saying about electronic health records data also apply to the claims data. So the first thing is terminology normalization, because not all hospitals, not all systems are using the exact same standards. So for example, we use the ICD codes, ICD-9, ICD-10 codes for claims or for billing purposes, but at certain time period, let's talk about 2015 or 2014, we can use ICD-9 or ICD-10. We don't have an exact obligation which version you need to use. Some hospitals use this version, some hospitals use the other version. There is also some departments would prefer to use SNOMED codes for recording their diagnosis information rather than using the ICD codes. So ICD codes mainly for billing, but for day-to-day purposes or for information exchange between different departments, they prefer to use the SNOMED codes. All are giving same meaning, so which terminology we need to use, what we need to do. So actually this is like a whole line of research we have done, and we summarize everything, or our code is actually available now in this GitHub repo, which is PyTorch EHR. We have used we developed our pipeline. There is a lot of things, a lot of work that has been done since 2016, since 2017 till now, and we have like amazing publications out there. And I am so proud of the MRSA culture result forecast. This is like recently published in Nature Communication by Dr. Nigo. And I am especially proud of this work because Dr. Nico take the lead of doing everything using our PyTorch EHR framework. I always say PyTorch EHR is somehow developed by clinicians for clinicians to easily use them. You don't have to be extremely like a deep learning geek to do that, train your model. You can just like be familiar a little bit what is these tutorials are doing, understand the data you are using, and you can train whatever model you want. You can train machine learning models, you can train state-of-the-art deep learning models. So this is some of the things that we are so proud of. So yeah, one of the other papers that we published here was COV-RNN. It is mainly for the COVID outcome predictions. Some people, the model itself is open sourced. The model was trained on 500,000 patient data from certain real world data, and they give us permission to share the model. So the model itself is available on the GitHub repo, and some people consider that a foundation model. Me personally, I don't consider it a foundation model, and I will tell you later why. But the main idea is that we use all the patient information among the different visits. We consider the time difference between the visits, and we train our models. In the COV-RNN work, we trained a binary classification model just to see if the patient risk for yes, no, for in-hospital mortality, for example, but also we have the survival model, which can also predict the time to event. And actually, this work was published in the Lancet Digital Health. Okay, so one of the main things that we find out from our very first paper published, that is the more data, the better is our AI model. And this is true. This is something we cannot hide. And that is what is the success of the large language models. They are not just big models, large parameters numbers, but also they are trained on huge data. And this is actually what we have done like long time ago. So in our first paper published in GPI, we find out like we trained one model for the prediction of heart failure on more than 1.2 million patient data. And if we compare a model that is trained on every single hospital on this data, and what is the performance of their the model trained on this hospital versus the generalized models that trained on the large data, you will always see that there is an increase in the performance, which is meaningful. And we are having an abundance of structured EHR data. We are actually, this is why I love working with these data more in any other type, because first, it is de-identified. I don't have too much risk about like patient identification, privacy stuff. Second thing, we have amazing resources over there. We started with Cerner Health Facts, and we get access to the Cerner real world. I highly, I'm very grateful for our school because they give us access to such great resources. So we use the Optum data. We use the N3C data. The N3C data is actually available for anyone. You just need to, same as all of us, you can just apply for the access, provide the training, and get your institute registered there. It is free to access, and it is a huge data set as well. We have, I think, more than 28 million patient data there. Also, we have like the IQVIA data, the IPM mark scan, but also we have nowadays Epic Cosmos, and we are trying hard to push to improve the computational resources there. Because data-wise, it is really of a good quality and good quantity. They have nowadays around 270 million patients, but still we have like a little bit struggles with the computational resource. Hopefully it will be solved soon. So now I'm talking about what is foundation models. So when we talk about foundation models, I have personally 3 criteria over there. The first thing that is, it is trained on broad data set. And when I say broad data sets, I mean 2 keywords, large and heterogeneous. So it is not just from one source. It is trained on sources, on data collected from different states, from different hospitals, even can be collected from different countries. This is very important thing to improve the generalizability of your model, and that is what will make it a foundation model. Second thing is that it is trained by self-supervised learning. And the very easy way of explaining what self-supervised means, that you just hide a part of the input and try to predict it, either a part in the middle or a part of the end. So all the GPT models, those are kind of autoregressive models, try to predict the next word. So you always mask the later word and try to predict and go on. PERT model, which is like our MedPERT was based on, it is mainly based on masking language models. That means like I have the whole patient history, all those codes, I will just like select some of them, mask them, and try to predict what is there, like kind of a fill in the space. And the last thing that is this foundation model will always work for us as a kind of a base for a more specialized model that we can build. This can be based on prompting, this can be based on fine-tuning, or whatever. So we normally, in the area of the clinical foundation models trained on structured data, especially we have small models, we prefer to do fine-tuning. But when we talk about clinical foundation models, this is like a kind of multiple or multimodal information that can be there to train those clinical foundation models. And they will help to solve a number of downstream tasks. Some of the examples that Dr. Huashu already showed, but was examples I will focus on here today is more into predictive modeling, medication recommendation, and a little bit on patient similarity. So when I talk about MedPERT, MedPERT is an early foundation model trained on structured clinical data. I think by the time MedPERT was published, it was the second. We have like another team in Oxford developed the PHRT. We're working actually at the same time developing somehow similar thing, but the advantage of ours that we were trained on the largest data. we were trained on 20 million patient data. They only have 1 million patient data from the CPRD from UK. We are using 20 million patient data from Cerner Health Facts from US. It is based on PERT. That was a state of the art at that time. It is no more, but it is really good in encoding information and learning those good embeddings that help boosting the other kind of predictive models. And when we designed the model pre-training task, we used 2 tasks just to imitate how the PERT model was trained. So the first one is a mask code prediction, which is like the core of the self-supervised learning. But the other task, we find that the PERT model was having another task which was mainly a binary classification task. We wanted to use a binary classification task that actually will learn from both directions, because PERT, the first word in PERT is bidirectional. So it learned from the past and from the future as well. So what is kind of a task that is not in having a kind of a label leakage or improper way of training the model, but also it is informative? We were thinking about 2 use cases, or like 2 tasks that are more or less related to the quality of the healthcare. The one was a prolonged length of stay, and the second one was the readmission. And by our testing, we found the prolonged length of stay was more helpful to the model. So this was our pre-training task that we decided on. And then we have our downstream task that we evaluate. All the models, actually, we still evaluate using these 2 downstream tasks. Is the diabetic patient's risk for heart failure and the patient risk for pancreatic cancer. And I am so proud of that pancreatic cancer one, because I think all other researchers who are working on clinical foundation models found these use cases an interesting one, and they always use it as a kind of a baseline performance evaluation for the different clinical foundation models developed. Okay, so when I am talking about the downstream task, this slide might look a little bit technical, but it is just like the inner working of our MedPERT. So we take the patient data, the input, like just the list of ICD codes we have here. We have another version using medication and procedure as well. We also have the serialized embedding, what represents the order of these codes. The ordering here is mainly based on billing priorities, and we have the visit embedding. So this happened in the first visit, second visit, third visit, until the last visit in the patient record. And we have this is converted somehow into vectors that is go into the transformer layers and learn that what we call the context vector at the end. So the patient become a kind of a 3D tensor representation here, and this is what we give it to a classifier. This classifier can be just like a linear layer, or it can be an RNN layer, whatever we want to use, and we get a kind of a risk score for the patient. So just to summarize what I have said here, so we trained MedPERT. We have different variation. We have trained on 20 million, 50 million. We have now another version that is trained on more than 100 million patients. And we fine-tune this on smaller local data, and we get a more specialized model based on the task. And as you can see here, we can achieve more than 20% boost in the performance. So if it is a model that is trained on 300 samples, this model is giving 55%. It didn't learn anything, but if you start with the MedPERT model, you can reach up to 75%. The same, you see, we have for the the diabetes, heart failure prediction, the pancreatic cancer, and also we already have the visualization here to show or to explain the inner working of the model. So this is showing the correlation between codes like chronic pancreatitis or acute pancreatitis to something like abdominal pain. So it shows like the correlations or the attention between different codes happened within the patient trajectory. Also, you can see here, this is like in one visit, and the code is repeated in the second visit, and how they are related or correlated to other codes in different visits. MedPERT v1 have some limitations. So MedPERT v1, which was published in NBG Digital Medicine, only trained on diagnosis data. The model we started that we planned to share, but we couldn't because at the time, Cerner bought by Oracle, we didn't get the approval, or even we didn't ask to get the approval to share the model. We couldn't share the model. But later on, we were working with Optum. With claims data, we get an approval from Optum to share the model. So we have a new version of MedPERT. It is trained on around we have a one trained on 20 million, one trained on 50 million. This is get approved to be shared with users. And it is trained on diagnosis, medications, and procedures. So it is using larger vocabulary. And even it is later. And you can see that we evaluated the model on different downstream tasks. So instead of the original diabetes, heart failure, and pancreatic cancer, we also have other diagnosis codes. And this is from mimic data. So this is mainly to set a benchmark for other clinical foundation models to compare against. Besides the work on predictive modeling, we also work on medication recommendation, and you can see that is for medication recommendation, you can see that MedPERT v2 model can achieve a better performance of around 94% compared to 89% using a baseline model. So this is actually the link for our MedPERT. We are proud of having more than 550 citations, which is not bad in our domain, and around 250 stars. And we have I think through this link, you can access a form if you need to request access to the pre-trained model. But we were just the start. Everything I was just saying, we were just starting. This domain is evolving. And actually, I got my first R1 based on this work, and we are working to improve that much more. But if I just highlight a little bit of the work is happening, I would highlight on 3 different categories. So as I mentioned, the first thing is, if you remember the MedPERT model, it starts with the embedding layers. And if you look at the embedding, we mainly hear that code embedding, we just have code embedding, position embedding, and visit embeddings. But other work are really doing smart things over there. So the CHR-PERT, which was published in 2021, they wanted to add the time information in a more innovative way. And this is what they come with, the artificial time tokens. So in MedPERT, we get rid of any tokens. We don't have CLS tokens. We don't have a separator tokens. We mainly use linear layers on the top of the context vector and then whatever we want to do afterwards. They are adding those information as a special tokens. So this was a nice way. And actually, we tested. It doesn't improve the performance much for us, but it is a nice way if we need to consider the time information for different downstream tasks. Looking at HR Mamba, which was a couple of months ago, published on arXiv, they adding more and more level of information to the embedding layers. So they have the token type, they have the age. Age is similar to PHRT. They added the time. They use the segment and the visit order, which I see them somehow redundant, but that's what they use. And they also have the position embedding. So we can add more on this embedding layer and learn better representation of the models. The other thing that I want to highlight here is a model architecture. So we started with a PERT model. So MedPERT is a PERT model. PHRT is a PERT model. Also, the CHR PERT is based on the BERT, but BERT is, as I mentioned, is an encoder model, and it is much better if we are doing representation learning. But also they use the decoder model, and they have the CHR-GPT model, which they published recently. Also, it is on the archive. It is a preprint. And they focus more on synthetic data generation. And this is a kind of advantage of this GPT model. We also have like encoder-decoder models, such as a transform EHR, which is actually was trained on the VA data. Also, we can innovate more on the pre-training task. And actually, this is one of the smart ways of using different pre-training tasks. So here, Motor, which was developed by the Stanford team, they are using, instead of like masking and prolonging length of stay, they have around 8,000 pre-training tasks. And they are doing survivor-related tasks to pre-train the model on. So this is also like ways of innovating on how to better train a more generalizable and more accurate foundation models. So talking about like the downstream task design, this is something we find actually also by experiments. So this is some of our work, which is like under review for publication. We were formulate like the downstream task closer to pre-training task. We find like when we do this, we enable few-shot learning. So MedBERT is not really good in few-shot learning by itself. So we were thinking about prompting. It might help the few-shot learning, but we find out that is when we formulate the downstream task to predict the token that is represents the disease that we are wanting to predict. So for example, if we, instead of having a head or a classifier to predict patient risk for pancreatic cancer, yes or no, we just try to have a mask token and predict if this token is pancreatic cancer or not. So just doing that, the performance improved, especially for few-shot learning when we just having few tens or maximum 100 sample. Another approach, which is also used by EHR Mamba, is a multitask prompt fine-tuning. So they are using special tokens for different prediction tasks. So if they want to like fine-tune on mortality prediction, readmission prediction, prolonged length of stay, different diseases, each task will be just as a prompt, and they use the hidden state at this prompt, at this token, to do their classification or like prediction task. So this is also like kind of state-of-the-art work. There are open sources, as I mentioned, MedBERT v2, we have it open. You need just to apply for access, and we keep the records, and you need to submit a training. And I think the same is done by the Stanford team, so similar process. And this is like our resource, but also I see these resources also as a helpful clinical foundation model resources. As I mentioned, those are by Stanford. Climber and Motor are their models, but these are models that are trained on like few hundred thousand patients. And the EHR Shot and the Inspect are kind of open source data sets. They use it to evaluate their models on. So this is actually good resources if you want to play and start working with the clinical foundation models for real-world data. So this is actually what I'm currently working on. I am so grateful to get this funded by the NLM, and I am so grateful for my advisors, my collaborators, Dr. Z, Dr. Hua Xu, Dr. Tao, Dr. Fei Wang, and my clinical collaborators, including Dr. Nigo and the whole team. Thank you so much, and I'm open for questions.
Hi, thank you for the wonderful talk. It was really insightful. My question is more of an opinion-based question for you. Regarding the slides where you were comparing it to your baseline model, which was just a simple logistic regression model, in terms of performance, it's more of a 4 to 5% increase. In terms of how energy inefficient large language models are, Do you think we are, as an AI community, overestimating this line of research? Is it more influenced by the industrial tech giants who are offering this line of research?
Okay, so just to answer your question, MedPert was trained, I mentioned like in 2018, 2019, we were training the model. The model was trained at a time, I'm not sure it was a A100 or even the version below that, and it was trained on just 1 GPU. And yeah, it takes longer time, I won't deny that, but it can be small resources and the model itself is small. I can tell you the same for the Climber and the motor models. They are 100 million parameter models. MedPert doesn't exceed the 20 million, by the way. But so it is not like really the big giant tech companies. It's like for the computational resources, we can train these models with good computational resources, like with medium-sized computational resource. But the important thing is the data. I think the data quality and how generalizable this is important. And I think we had advantage over large tech companies. Because, for example, in order to access the Cosmos data, you have to be affiliated with a customer. You don't need to be a big tech company. So we have advantage over them. Sure.
Thanks very much for this amazing presentation. So I've read your papers before, so thank you very much. So I have a question regarding this foundation model. So say if I have a particular disease I want to predict, which I don't know if it's being trained with the foundation model yet or not before. So how much fine-tune work you are expecting, and is there a requirement on the data to make a good prediction on such?
Okay, so this is a good question. Thank you so much. So I can tell you a few things. So adding a new token, new disease that is a model was not trained on, this is not helpful. So this is a situation where I see the foundation model is lacking. We tested the out of vocabulary, adding those additional tokens to the models. But if your size of the fine-tuning data is pretty small, it really don't help. And training a new model just for this will be helpful. But the advantage of the using large data, heterogeneous data for the training of your foundation model is a key for that. So you have like the minimum possibility of having those kind of out of vocabulary or having those diseases that you are not training on. So this is like an important thing, but this is like a bad question. Thank you.
Thank you so much.
Okay, then let's thank Laila again for the great presentation.